All right, we're gonna get started in a few seconds while people are joining. All right, so hello everyone, and thanks for joining How the MetroHealth System Reduced Denials with Value Set and Improved Coding. Before we get started, I want to take care of a few items for those attending. This webinar is being recorded and will be available to you for future viewing. Today, we will be joined by Dr. Peter Greco. He's the Director of Informatics for Software Infrastructure at the MetroHealth System, along with Eric Sarconi. He's the Director of Patient Financial Services and Revenue Cycle at the MetroHealth System. And then we have Megan Broom. She is our Product Sales Director at IMO Health. So as mentioned before, if you have any questions or comments while our team is speaking, just type them into the Q&A box, and we will have a Q&A session at the end of this webinar. So with all of this being said, I'm going to go ahead and pass it over to Megan.
Thanks, Jordan. All right, welcome to our webinar today. We're really excited in order to show off all of the work that IMO has worked with the MetroHealth System on over the last several months. I'm sure many of you, I just scrolled through the attendee list real quickly before I started talking, talked to many of you about this solution so far. And there's been a lot of excitement from the community about our administrative coding assistant sets. However, there was also a really strong desire to be able to see this up within an Epic workflow and to see what this looks like on the provider side. And so we are very lucky to be joined today by Dr. Greco and Eric, who are going to run through from both a provider perspective as well as the revenue cycle perspective, the enhancements that IMO and Metro were able to work on together in order to help reduce overall denied claims, as well as just improve efficiency across the provider workflow and the revenue cycle. Reason that IMO has worked on this solution is because we know that healthcare has a data problem, and it affects everything from patient care to our reimbursement to our downstream efforts around our data. If we don't have a solid strategy in place in order to maintain the terminology that's being captured at the point of care, add in any additional insights that help us get to a more specific code that, yes, is great for reimbursement, also great for patient care, also great for just better quality data overall. IMO has been around for 30 years working in clinical terminology. Content is one of our biggest specialties that we have. And so this is why IMO was well suited in order to create this content and maintain this content that the MetroHealth system has then been able to use within the Epic system in order to help solve for a problem around denied claims in really these two buckets. So non-primary codes, unspecified codes, these are comprised of many different types of code groupings, things like external cause codes and manifestation codes, things that are great for documentation, but can't go out the door as your primary diagnosis. Similarly, things like unspecified laterality then ultimately causing denials and really kicking off what I've talked to many of you about over the last several months, this denial cycle. And how can we avoid that denial cycle by catching these as upstream as possible? So that's really why we've created our administrative coding assistant sets. And with that, I look forward to hearing Dr. Greco and Eric share more about the solution within their system. So with that, I will go ahead and stop my screen and pass it over to the team.
Thank you very much. Just as a reminder, these screenshots are all copyright 2024 Epic Systems Corporation, and this is intended for customers of Epic Systems Corporation only. So if you're not one of those folks, please leave the meeting now. All right, let me move on to the next slide here.
Oh, Dr. Greco, I don't think you're showing your screen.
Oh, I'm sorry.
That's okay. On the bottom, there's the share button.
Yeah, I tried it, and we'll try one more time.
There
How's
we
that?
go. Yep, perfect.
Okay. All right, here's our copyright reminder, which I already told you. Okay. Eric?
Yep. So nice to talk to everyone. Excited to present what we're doing today with the IMO administrative coding sets. and like Dr. Greco said about the copyright notice. So first, I'll just give a quick rundown of the agenda and what we're going to go through. First, we'll discuss the problem to be solved, which is the appropriate coding for unspecified and primary diagnosis. We'll jump into the strategies, the build, and then we'll have some time at the end for some questions. So first here, I'm going to chat through the problem and then let Dr. Greco discuss the solution. So next slide. So we've started to see a growing number of payers deny both professional and facility claims for unspecified laterality and unacceptable principal diagnosis. This has really started to shift and grow over the past year or so. It's always been something that certain payers have done, but it seems like more and more are starting to jump on that bandwagon. So we wanted to try to come up with a solution to avoid the unnecessary work that we're doing post-service and having to have coders go in and review, or having follow-up staff have to work through denials. So we were trying to find a solution that we could ultimately present to a provider to avoid this change in payer policy. So unacceptable principal diagnosis, they come in many different flavors, like Meg said, external cause of injury, manifestation codes, sequela codes, codes that can only be in the secondary position. So that was the one subset that we wanted to tackle, and then laterality being the other. And the problem, as we kind of started to dig into this, was providers don't know all of the coding rules or how to fix all of the coding issues that come up to them. So how do we present things to providers in a manner that they will understand and easily be able to correct without having too much unnecessary burden placed on them? So next slide. So here I just pulled out a couple of the more recent payer policies to kind of show this is 3 different payers here in Ohio that are focusing on and have put these new policies in place within the past year, stating that they will deny claims if, in most instances, both laterality and inappropriate primary diagnosis are in the primary position. We've even seen some that are as specific as if laterality is anywhere in there, regardless of whether or not it's in the primary position, they will start to deny claims. So obviously, this is going to have a major impact on us as we continue to move forward. So now I will turn it over to Dr. Greco to get into the solution that we've been working through.
Thank you, Eric. So we're going to talk about 2 things. One is diagnoses which can't be primary, and the other is unspecified laterality. So I'll be switching back and forth between those. But they both are the same problem fundamentally, which is how do you identify that a diagnosis can't be primary, and how do you fix it? So essentially, I broke this down into 3 problems. One is you need to obtain a list somehow of those unacceptable primary diagnoses or those diagnoses which don't specify laterality. And I'll cut to the chase. The way we get that list is from IMO. That's why we're here today. The second thing we have to do is we have to somehow check that primary diagnosis before the provider closes their encounter. Because if we wait until after they've closed the encounter, then you get into the realm of denials and rework and so forth. So the third thing you have to do is, if you find a problem before the encounter's closed, tell the user what's wrong and how they can fix it. And again, this information we're getting from IMO, as you'll see. So getting the list of unacceptable diagnoses, we actually explored whether we could get this from publicly available sources. CMS does provide this, but it's not easy to use. It's not in an import-ready format for use in Epic. You can put it in that format, but it's a lot of work, and you'd have to do it every year. And the other problem is that when you base your groupers in Epic on ICD-10 codes, it can pull in some good codes as well as some bad codes, because these ICD-based groupers will include diagnoses for which any of the ICD mappings is found in the grouper, not just the primary mapping of that diagnosis record. And then the third issue with the publicly available files is that the codes aren't categorized in a useful way. And so it becomes more difficult to customize the message to the user about how to fix it. And there's no way to prioritize what you want to alert people about. Maybe you don't want to alert them about every possible error that they could make, at least initially. So again, the second step, we have to figure out a way to check the primary encounter diagnosis. Now we do this using what are called encounter validation extensions, and pretty much every Epic customer is using these. This is how you make sure that there is a diagnosis. This is how you make sure there's a level of service, that sort of thing. And these can be warnings or hard stops. And they can hyperlink the user to the place in Epic where they can go to fix whatever the issue is. And I'll show some screenshots of that. And then the third piece of this is tell the user what's wrong and how to fix it. And the key tool for that, again, is an encounter validation extension. And I'll show you that. Now, one of the great things about encounter validation is you can use rules. So which means if you can write the rule, you can get the message that you want to the user. And you can also put multiple rules into one extension, which really simplifies the build in a lot of ways. Because if you've ever had to configure a profile for encounter validation, you know that these lists can be very long because you have to list all the encounter validations you want to run for every encounter type that you want to run them for. So with this multiple rule extension, the user will see whatever rule message applies to any of the rules that were true in your extension. So again, I'll show you an example of that. Now, one thing you really have to be aware of, there may not be a primary diagnosis at the moment in time when you perform your encounter validation. We learned this the hard way, but maybe you won't have to. There's a profile item which you can set to default the first diagnosis that a person enters to be primary, but we don't do that. And because of that, it means that when the person is closing their encounter, if there's only one diagnosis on the encounter, it might not be marked as primary. So our rules have to check for two things. The first thing it has to check is whether, if there is a primary diagnosis, that primary diagnosis is bad in some way. But if there's not a primary diagnosis and there's only one encounter diagnosis, we have to check that as well. That will obviously become the primary diagnosis after the encounter gets closed, but before the encounter gets closed, it's not necessarily yet marked as primary. Again, your system may be configured differently from ours, but this is an issue for us. And so we came up with this strategy. We have one rule that checks whether the primary diagnosis is bad. And if so, that message indicates to the user, hey, your primary diagnosis is bad, and here's what your primary diagnosis is. We have a second rule, just in case there isn't a primary diagnosis yet, which checks for one encounter diagnosis, not yet marked as primary, and which is bad. So it functions essentially the same as the first rule. It looks exactly the same to the user, but behind the scenes, there's two different rules. And then we have additional rules, one for each of the various groupers that you can license from IMO, such as external cause of injury, manifestation, et cetera. And if the diagnosis is in one of those groupers, and it's only going to be in one of them, it can't be in more than one of them, that's going to display a more specific message to the user about how they can fix their primary diagnosis. So in this slide, here are 4 examples. The user is never going to see all these things at the same time. This is from 4 different encounters. Starting on the upper left, we have an example of an external cause of injury. So the first rule says your primary diagnosis is not allowed for billing. It gives the name of the diagnosis and its ICD-10 code. And then the second rule, because this comes from the external cause of injury rule grouper, tells the user, please use as the primary diagnosis the injury or problem. So we're telling people that their diagnosis is bad, but also how to fix it. The one below that is from a manifestation grouper, endocarditis and diseases classified elsewhere. Here, the message to the user is a little bit different. Tells the user to use the underlying disease, i.e. whatever's causing the condition you chose as primary. Now, I should be clear, the wording in these is entirely up to you. IMO has provided us with suggested wording for these, but you can use whatever wording you want to. Couple more examples on this slide. The one in the upper right corner of the slide is from it's sort of a, I don't want to call it a wastebasket category because that's not fair to IMO, but there's a lot of things that if it's not categorized as a manifestation or an external cause of injury or an obstetric code or any of a number of other things, it ends up in this bucket. And the family history codes are in this bucket. And here the message to the user is, don't use that as primary. Tell us what condition you're treating, or if it's appropriate, use encounter for preventive care. And we've tried to put messages there where it says, if it says to use encounter for preventive care, the user should be able to type that and find a diagnosis. Same for that obstetric example, the final example here, where you can't use 8 weeks gestation of pregnancy as primary, but you could use encounter for supervision of normal first pregnancy or encounter for supervision of high-risk pregnancy, what have you. So the message is customized based on the type of problem that occurs. And I don't show an example of it, but the laterality message would be similar. So we'll get to unspecified laterality next. And I should mention that I learned a lot about unspecified laterality in investigating this. I really didn't understand the problem. And I think I understand it a lot better now, and I hope that knowledge will be beneficial to you. What I learned is that unspecified laterality comes in 3 different flavors. I like ice cream, and I always think about, when I was a kid going to Baskin Robbins and the 31 different flavors. So I would like to talk about flavors. And it's the first day of summer, so let's talk about flavor. So one flavor is that the system defaults unspecified laterality in the diagnosis calculator, and the user doesn't bother to change it. So that's the first pathway that you can get unspecified laterality. Second category would be, or second flavor, is that the user specifically chose unspecified laterality in the diagnosis calculator. They could have chosen left or right, or maybe in some cases bilateral, but they didn't. They said, no, I am going to not specify laterality. I clicked the button. And then the third example, or third flavor, is that it's a diagnosis that's inherently not lateral, and it's not configured to use the diagnosis calculator. So here the user just found a diagnosis they liked, and there's nothing more they could do. There's no way they could give us laterality in that diagnosis. So these are the 3 ways you can get unspecified laterality. So how do we avoid getting unspecified laterality now that we understand how it happens? So the first thing we did was we said, well, let's just not default unspecified laterality. We didn't even realize we were doing that, but our system was configured that way. And so I'll show you how to turn that off if you also are defaulting that. So that's the first thing. The second, which you may or may not want to do, it's kind of a lot of work, but we decided to try it out. You can actually configure some of these quote unquote bad diagnoses to use the diagnosis calculator, or you can ask IMO kindly to maybe to fix some of your favorites that aren't configured that way. A third thing you can do is you can hide certain diagnoses from lookup. If it's a diagnosis that doesn't specify laterality and you don't want people to pick it because you think there's better things they could pick, you can actually hide it from lookup. Again, this was something I didn't know. Seemed like a really useful thing to know. And then the last thing, of course, you can do is close encounter validation when despite all the changes to workflow that you've made, they still end up with unspecified laterality. You can warn them or hard stop them when they're closing the encounter. So just for fun, I created this run chart that showed how many encounters per month we had with unspecified laterality as a primary diagnosis before and after we turned off the defaulting of the modifier. And you can see in the red section of the graph that it did drop, noticeably, probably by about, 25 or 30%. So it helped a little bit. It didn't fix the problem. So what else are we going to do? Well, again, we can hide diagnoses from lookup, the ones that don't specify laterality and which don't participate in the diagnosis calculator, and that they're not uniquely valuable to users, i.e. there's other things they could have chosen. I'll show you some examples in the next slide of what we're going to be hiding from lookup because they meet all these requirements. Chronic osteomyelitis. Well, the problem there is to get laterality, you also have to get a site, and this diagnosis won't get you either. So there's really no way for us to fix it. Similar with avascular necrosis. You don't have a site, you can't get laterality. So if you ear infection is another good one. That's a dead end. You don't know which ear, you don't know what kind of ear infection. People should be able to tell you a little bit more than that. So these are examples of diagnoses that you could hide from lookup. We chose these just because these were being chosen frequently. They were near the top of the list. So how do you hide them? You put them in a grouper, just like I showed you, and you create an extension which points to that grouper, and then you put that extension into the relevant profiles. I have screenshots that show the exact steps of where to do that if you're interested. Now, one thing you should know about hiding diagnoses, people can still find these diagnoses from the problem list or from previous encounters. So even though they're hidden from diagnosis search, people can still find them through various means. So in some cases, you might want to hide a diagnosis from lookup, and you also might want to configure it to use the diagnosis calculator. That way, if they do happen to find it somehow, then at least you would get the diagnosis calculator to pop up. So sort of a belt and suspenders approach. Let me talk a little bit about modifying behavior of the diagnosis calculator. By default, all these diagnosis calculator behaviors are determined by IMO, but I like to tinker with things, and I found out that nothing prevents me from enabling diagnoses to use the diagnosis calculator. And it's actually pretty easy, and I'll show you how it's done. It's really just two steps that you have to take. First is that you have to go into that diagnosis record and say that laterality is an allowed modifier type. And then for each of the modifier values, which in this case is going to be left, right, and sometimes bilateral, you need to find a specific diagnosis that corresponds to that laterality. And it's perfectly fair game to use other diagnoses that are already connected to the diagnosis calculator in other ways. And I'll show you an example on this next screen here. So I found this diagnosis wax in ear, which is a dead end. Which ear? Who knows? So I made two changes. I added laterality as an allowed modifier type. And then for bilateral left and right, I found more specific diagnoses. So now when a person chooses the diagnosis wax in ear, they have to tell us which ear. And if they tell us that, which they have to, then we get a more specific diagnosis. So problem solved. Now, some caveats here about if you do choose to go down this route. These customizations might get overwritten by subsequent IMO loads, so you would need some sort of a backup plan. The diagnoses that you choose as endpoints could potentially become invalid diagnoses. Maybe, the IMO decides to do something that diagnosis isn't valid anymore, or ICD-10 adds another digit, that sort of thing. Users might adapt. They might find some similar diagnoses that you didn't configure. They may do anything they want to avoid the diagnosis calculator. And then sometimes you can't get the exact same wording. So they chose wax in ear, and they end up with diagnosis excessive serum. And, it means the same thing, but people can be picky about what they like. So people may or may not, find that to be problematic. So let's talk a little bit about results. And to be fair, these are all of this stuff that we're talking about is actually, with few exceptions, not yet live, but going live next week. But in preparation for that, I can show you historical data about our diagnosis usage. So I looked back 3 months and looked at the number of encounters where there was a bad primary diagnosis by IMO grouper category. So this gives you an idea of what some of the groupers are that IMO has available. This not valid as primary diagnosis category was the largest one. That was the one where family history of colon cancer came from. That was the most common category that we saw. External cause was a very close second, followed by manifestation codes, obstetric information, and social determinants of health. After that, things fall off quite a bit in terms of frequency. So you've got some heavy hitters there, and then some things that aren't that common. Now, that's our system. Your system may differ. Depends on, maybe you have a vascular dementia specialist, and that's all they see is vascular dementia all day. You might see a lot more of that. This is showing historical data going back to the year 2000 using slicer dicer. I actually ran this morning. I thought, well, maybe this would be interesting to look at, and it turned out it really was. This is the number of encounters per year with a primary diagnosis that was in the not valid as primary, our top category. And what's interesting is that in 2016, things improved quite a bit, which is, the first full year of ICD-10. But ever since that, it's just been getting worse and worse. And I guess because we've not been doing anything about it. So this one's really been on the rise, and not surprised that it's number one. External cause of injury is a very different story. That was doing, really bad until 2014 when we implemented some validation. This is back in the days of ICD-9. I think some people might remember those as E codes. I think that's what they were back then. Again, things got a lot better for a while, and then they've just been getting worse every year since then. So again, this is our number 2 category of bad primary diagnosis. And as a final look back into history, just for fun, this is unspecified laterality as a primary diagnosis. And this is the only one that you might look at it superficially and say, oh, wow, this looks good. But you have to notice 2 things. One is that the y-axis is way different on this graph, and that we were seeing unspecified laterality more than 100,000 times per year. And now we're seeing it, quote, only 30,000 times per year. Well, that is way more than external cause of injury, and that's way more than unacceptable primary diagnosis. So why did this one drop? Well, that's very simple. ICD-9, which was in play until October of 2015, had no concept of laterality. So there were lots of unspecified laterality visits in the ICD-9 era. Once we got to ICD-10, things improved a lot because now you could specify laterality. But I think the key point in this slide is that about 1/3 of the time when people could specify laterality, they simply don't. So this is a big problem. Even though it's a lot better with ICD-10, it needs to be addressed. So based on all that previous data, we decided that we were going to focus on these 5 groupers from IMO plus the unspecified laterality grouper as the ones that we would focus on. Initially, we're not going to worry about the other categories just because they're not that common. And I think they're a little bit harder for people to understand how to fix. Vascular dementia, I remember in meetings, complaining about that one, saying, well, what's wrong with that diagnosis? And I'm still not satisfied with the answer. So I thought, well, let's not fight that battle just yet. So conclusions. I think that these IMO administrative groupers will enable us to give precise messages to the end user about bad primary diagnoses. Effective use of that content does require you to build some rules, and you can make them as detailed as you want to or as general as you want to. And the final conclusion is that system configuration can reduce unspecified laterality to some extent, but I think you'll need some groupers to do a better job with that. As I mentioned, I do have some slides if anybody is interested on the nuts and bolts of, screenshots of how to build all this, but in the interest of time, I've set those aside for now. And I thought we would stop at this point for discussion. So thank you very much.
All right, so now is the time that we'll go through our Q&A discussion. Please put any questions that you have in the Q&A box. So when you make changes to the EDG record, does your IMO load overwrite your changes? Meg, that might be a question for you.
Sorry, actually, I don't know, Dr. Greco, do you want to talk about how you're planning to overcome the overwrite?
Yeah, we can. Let me. Yeah, here's an example of. Actually, I showed you an example of this already, but what we're planning to do is basically just to. I mean, you can back up your customizations. We're talking about maybe 50, 60 EDG records here that we decided to focus on, not 10,000, not 100,000, not 1,000,000. I mean, we don't have the time to do that. We think that they'll probably get overwritten, but basically we're just going to back them up and re-import them to get that, to make sure we don't lose it.
Yeah, and hi, this is June with IMO, and along those same lines is also for that overwrite, most likely it would occur. Dr. Greco just mentioned how he's backing it up, but the other piece of this is through this collaboration, we are also looking at having those added as part of the standard offerings around our content for that. So it doesn't have to be a user managed element along those lines. So that is also from IMO's perspective, another great aspect of this partnership that we've been able to identify and help work through this.
Yeah, and I should be absolutely clear. You certainly don't have to do any of that. You could, if you wanted to say, look, we don't want people to look up those diagnoses if they're a dead end as far as laterality is concerned. That's a perfectly valid approach. I'm kind of a nice guy. I hate to, to be draconian about things. I sometimes I shouldn't be as nice, but I'm trying to be nice and make it easy for people. There were some other questions in the chat. I think there was one about, let's see. We currently receive our diagnosis files from IMO. Was this a completely manual build to complete, or did IMO contribute to this customization? What was really interesting about this is that we had a back and forth with IMO, where initially we got basically a few very large groupers from them. And what we realized was that these large groupers, although they were useful for identifying that there was a problem, they weren't so useful in helping the user, understand how to fix the problem. And so what ended up happening is that IMO came back with more and more refinements, and ultimately we ended up with, what was it, about 16 different groupers maybe. each one a, different type of problem with the primary diagnosis. And so that's what IMO brought to the table was providing that specificity as to what was wrong with the diagnosis, putting those into different buckets. What we then had to do was build the rules that looked for whether the diagnosis was in bucket A or bucket B or bucket C or bucket D. And that's what all the rule building was about. So yeah, we had to build a lot of rules. In the end, since we're only looking at, half a dozen different groupers, there's five groupers for unacceptable diagnosis and then the one for unspecified laterality. So it's basically, six, there's a probably a total of 18 rules that you'd have to build to deal with six different grouper categories. And in our case, we have two different encounter validations, one which is a hard stop for some of the groupers and one of which is a soft stop for the unspecified laterality. Just because unspecified laterality is so much of a larger problem, I think if you started to put in a lot of hard stops right from the get-go, it would be a much more painful experience. So I think we're going to try to give people some time to get comfortable with fixing unspecified laterality. So yeah, so there's definitely a lot of build that you have to do, but it's really not complicated. I mean, I can, again, if we want to do that, I can, show like what these rules look like. I mean, this is a example of a rule that says, hey, your primary diagnosis is a manifestation code. We use a property called primary diagnosis, and we ask, is that primary diagnosis in a particular grouper? So if you want to do this for external cause of injury, the rule looks exactly the same, except you just have a different grouper in that rule. So these rules are not difficult to build. I mean, if you have spent any time with the rule editor, you should be able to do it. Somebody also asked, will these build piece slides be included in the link to this recording? I mean, because this is Epic copyrighted content, we probably don't want IMO to be the one distributing it. I'll work with IMO to figure out how to get that to people who are interested. There was a question about how you're able to gain buy-in from the providers. Well, I think partly we've been doing, I don't know if I mentioned this, we've been doing the validation for external cause of injury for many years. I think we've been, without having special groupers from IMO. And so people are already used to seeing these messages. I think this is just going to expand a bit the nature of diagnoses that they're going to see these messages for. Somebody asked, where do you specify in Epic whether a diagnosis is defaulted, whether modifiers are defaulted? This is in profiles. Here's the screen. It's on the diagnosis calculator / replacer settings screen. And it's the highlighted item there. Use default modifiers. We changed that to no. So that's how you turn off the defaulting of modifiers. Let's see, somebody said, I have a non-primary diagnosis grouper that will prompt providers if they submit a primary diagnosis that is not allowed. However, our IMO has ICD-10 codes that have multiple diagnoses listed as the primary. So one is acceptable, but the second one is not. What is an option in that case? Yeah, that's a great question. I do have an answer for that. I don't think I have a slide that shows the answer. It's a little bit, that one required creating some custom properties. I don't think it required any like custom routines or anything, but essentially what you have to do is find the first ICD-10 code, and then you have to find the EDG record that is what you might call the canonical record for that ICD-10 code. the one that the billers use. And then you have to find out if that record is in the grouper that you're interested in. And so your problem is solvable. It's a little bit complicated. I could probably write that up and explain it, but that's a great question. Are there other questions? Let's see. Who manages adding laterality into diagnosis? Yeah, I think we talked about that a little bit.
Dr. Glasgow, is there anything else you wanted to add over some changes IMO is making to the diagnosis calculator around laterality, just while we brought that one back up?
Yeah, IMO does build in as part of our content a lot of those laterality modifiers. We're really sensitive to data size too, though, so we don't automatically build it for everything. But any IMO users can request enhancements to those kinds of areas of us, and a lot of times we will add them to the standard load. So that is a route that you can take.
In case anybody's wondering how to prevent diagnosis lookup, that's real easy. You build an extension record here using type diagnosis exclusion code. You use code template MR diagnosis exclude by grouper, and then in the on the next screen, you just specify the grouper of diagnoses that you don't want people to look up. So that's your extension record, and then you plug that extension record into a profile. So this is our sort of main profile that people hit if they haven't hit a more specific one. And on this diagnosis search screen, you just specify that extension record. So when you do that, then all of a sudden they can't find, whatever diagnosis you don't want them to be able to find. Again, this is a small list. We're talking about maybe 25, 30 diagnoses that we've put onto this list. But there are things where we really think people should do a better job and give us something more specific. So we don't do this lightly, but it is an important tool.
Hi, Dr. Greco. This is June again. I'm curious from this collaboration and the work, if there's any type of time estimates that you could identify throughout the.
Okay.
Yeah.
Yeah, I mean, I think that's a great question. For us, there's a number of elements that went into building this. Partly, we didn't know what we wanted to build. Okay, we really didn't know what the solution was going to look like. I think we had an idea, but it wasn't like we said, okay, here's the endpoint. How do we get there? I think we kind of wound our way to the solution. So a lot of the time involved was in figuring out what the solution was going to look like, which then led to figuring out what do we need in order to get that solution, which led to what are the tools in Epic that will get us to be able to build that solution. Now that all that's been answered, if we had to build it again from scratch today, it would be a much quicker process. How many hours would it take? I think you could probably, importing the groupers, honestly, it literally takes, 10 minutes. IMO gives you import ready files. As long as you know which import specification to use, you FTP that file to your Epic server, you run the import utility, and you've got your groupers. So that step is like that's the easiest part of the whole thing.
Okay.
Once you've got those groupers, then you can go and start to build your rules. And again, if you wanted to, so here's an example of an encounter validation rule. I'm sorry. We'll go back to this diagnosis here. So let's say you wanted to just start by doing the manifestation codes or the external cause of injury codes. You'd build this rule like this one, point it to the right grouper, And then you would go and you'd create an extension record of type and counter validation with code template AN, which I think stands for anesthesia, close and counter validation template. And then within that, you would specify the rule or rules that you want that to run. Again, that probably take you, just a few minutes to build that extension once you have your rule. And then you need to plug that extension into your profiles, whichever profile it needs to go into for whichever encounter type you want to validate. So it's all pretty much bread and butter stuff. It's just taking standard Epic functionality and, putting it, connecting all the dots. Now,
Yeah.
if you want to put, 20 rules in your encounter validation, then it's obviously going to take you longer to build 20 rules than to build, 1 or 2 rules. But again, it's not, once you've got one rule, the next rule is basically identical except a different grouper. So it's fairly quick to crank these out once you're into it. So, you could probably I'm guessing you could probably be live with something like this with, if an analyst was working on this and this was all they had to do, they could probably build it in a week or two, I would think.
Great. Thank you. That's very helpful. Appreciate that.
All right, so it looks like the questions have winded down. Thank you, Eric. Thank you, Dr. Greco. Thank you, Meg, and everyone that was on Q&A. I really appreciate it. So we're going to go ahead and close out today. I hope you found everything in today's webinar useful. Thank you for attending, and I hope you have a great rest of your day.
Thank you, everyone.
Thanks, everyone.
Thanks. Bye-bye.